Good morning. Thank you to the organizers for the invitation to speak here about Herpes Viruses Infections. First, I will provide some introduction. As all we know, there are 8 human well-known herpes viruses. These slides summarize the relationship between herpes viruses and the immune system. First, herpes viruses evade the host innate immune system, producing primary infection. Thereafter, the host adaptive immune system, mainly CD8 T+ cells, are crucial for maintaining latency. These tables summarize all the viruses and the main sites of latency and the route of primary infection. Clinical manifestation of herpes viruses depends upon different aspects. First, if the patient has a primary or a reactivation disease, normally in immunocompetent patients, reactivation disease is less severe and shorter than primary infection. It depends on the anatomic site involved, since in immunocompromised patients we can have several visceral involvement, including central nervous system, ocular infection, lung, liver, and gastrointestinal infection. And lastly, is related with the setting of immunosuppression, since transplant patients, patients with malignancies, pregnant women, and older patients have a higher risk of severe visceral dissemination. We will try to focus mainly on 2 herpes viruses, herpes 1 and 2, and varicella zoster, since the use of PCR for this virus in the last year has changed the perspectives in clinical practice. As World Health Organization evaluated in 2012, herpes 1 and 2 have a very large burden all over the world. As we can observe, they estimated that about 77% of the patients are affected with herpes 1, and about 11% of the patients have had contact with herpes 2. This prevalence is highest in Africa and lower in Americas. Talking about the estimates of varicella zoster virus, we know that most data come from high-income countries, and that temperate climates where people are not vaccinated, most of patients have acquired the infection in mild childhood and adulthood, and there are some geographical variation with lower incidence in tropical countries. As we can observe in this figure, talking about herpes zoster or shingles, there is an age-specific incidence rate that is much higher all over the world for people that are older than 50 years old. Then we will talk about the possible diagnostic approaches for herpes 1 and 2 and varicella zoster virus. As all we know, we can use serology, which is really useful for large epidemiological studies and retrospective diagnosis, but rarely increased during recurrences. Regarding viral tissue culture, is well known that is the standard criterion for diagnosis, but it's operator dependent and can delay results about 2 or 5 days later, with lower positivity rates for varicella zoster virus and for genital lesions. Tongue smear is a cytological technique that is very quick but does not distinguish between different herpes viruses and has low sensitivity and specificity. Immunofluorescence is a short technique which yields rapid results and can be used on cells scraped from ulcers or tissue culture cells. But the mainstay of diagnosis for herpes 1 and 2 and varicella zoster at the moment is PCR, which has improved sensitivity and specificity for the diagnosis and is the preferred test at the moment for central nervous system and ocular infection. And the most important aspect is it can detect asymptomatic shedding and different samples also with low viral load. So, the approach with PCR in different clinical specimens allows to discover new interesting perspectives in clinical practice and research. First of all, we will focus on herpes 1 and 2. Herpes 1 and 2 are well known since the ancient Greek, and Shakespeare somehow has some familiarities with the disease since he referred to it in Romeo and Juliet book. Herpes 1 is well known that is mainly causing blisters and ulcers in oral area, whereas genital infections are mainly caused by herpes 2. But there are several other areas can be affected, including cutaneous manifestation and ocular infection that can have severe morbidity. It's interesting since in the last years we have all historically been thinking that the main cause of genital herpes viruses was related with herpes 2. However, in the last year, several studies have shown that herpes 1 is also an important cause of genital herpes. Mainly, it has been detected in developed countries since it seems that during the childhood, children do not acquire the infections and they can get later it with sexual contact. Is it a matter of relevance? Yes, it is, since genital herpes is different depending on the type of virus. Since herpes 1 does not protect against herpes 2 infection, herpes 2 has higher risk for symptomatic disease and recurrences. There are no data related to the risk of acquiring HIV infection related with genital herpes 1, and herpes 2 in neonatal herpes can produce a poorer prognosis compared to herpes 1. In relation with neonatal herpes, we all well know that it is a very severe perinatal infection that is mainly acquired during pregnancy and during the delivery. The higher risk for transmission is whether the women get the disease as a primary infection during pregnancy, and mainly herpes 2 has a poorer prognosis compared with herpes 1. Clinical presentation can be very severe with central nervous system involvement or disseminated infection. And in this case, diagnosis has to be approached with several samples where PCR, viral culture, and immunofluorescence can be performed. A new interesting matter related with herpes 1 and 2 detection in gastrointestinal samples comes from IBD disease. Esophagitis has been described as a reactivation of herpes virus for the vagus nerve or as a direct extension of oral lesions. And the diagnosis is supported by endoscopic findings associated with histological examination and also the use of microbiological identification based on viral culture or PCR. And in the last year, the use of quantitative and qualitative PCR has improved the diagnosis of this disease in different clinical patterns. And although most inflammatory bowel disease have usually been associated with cytomegalovirus reactivation, in the last year, several flares of inflammatory disease associated with herpes 1 and 2 have been described. In relation with herpes 1 and 2 hepatitis, we have to say that this disease is a very severe disease, mainly affecting immunocompromised and pregnant women. That is usually a severe disease that produces liver failure with a very high mortality. Also, in this disease, the use of PCR is fundamental, detrimental, since it allows detection of the virus in blood samples. Since patients sometimes cannot perform liver biopsy due to the high risk of bleeding, and serology cannot be reliable, since the patients may have false positive and false negative results. And in most cases, the typical rash is not present. Regarding respiratory infections, we all well know the croup herpetic disease in children, and we know that pneumonitis is uncommon and is mainly develops in immunocompromised patients as a direct extension from the upper airways. In the last year, there is a controversial matter that is mainly related for the detection of herpes 1 in respiratory secretions in mechanically ventilated patients. This is a very interesting matter because it's not clear if herpes 1 is a real pathogen or is only an innocent bystander, since in mechanically ventilated patients it has been detected from 5 to up 65% of the patients, and this patient has shown to have higher mortality that is probably related to the baseline disease, and there is no clinical evidence for direct pathogenicity of the virus, since the use of antiviral therapy doesn't seem to have a direct effect on the evolution. So herpes 1 is a marker rather than a mediator of a severe illness, but this is an interesting area where herpes 1 PCR should be used for research and for improving intensive care urine patient care. Second, we will approach the varicella zoster infection that is well known, that can produce primary infection well known as chickenpox, or an endogenous reactivation that is well known like shingles. Varicella mainly manifests as uncomplicated varicella, but in those patients with extremes of age and in persons with cellular immune deficiencies, there can be virally mediated or bacterially mediated complications. Virally mediated complications mainly are neurological, pneumonia, hepatitis, disseminated disease, and neonatal congenital infection. Herpes zoster or shingles may reactivate in sensory ganglia, producing rash and acute neuritis. Post-herpetic neuritis is the most common complication related to herpes zoster. But one of the most interesting data we have discovered in the last year, thanks to the use of varicella zoster PCR, is the role of varicella zoster in vasculopathies. We know that varicella can maintain latency in sensory ganglia, but also in sympathetic, parasympathetic, and enteric nervous system. So, varicella zoster PCR has allowed the detection of this virus in arterial walls. And since vasculopathy occurs following infection with pathological vascular remodeling, there are recent data that have been performed in different studies. This is a systematic meta-analysis studying the risk of cardiac and stroke events after infections, and they show that there is an increased ratio of risk of stroke syndrome and cardiac events in patients who have been affected by herpes zoster in the previous 12 months. Other interesting approach that has been performed thanks to the use of varicella zoster PCR is that after evaluation of vascular specimens with varicella zoster DNA PCR, we have found an association with giant cell arteritis and granulomatous aortitis. Probably this approach may change in the future, also therapeutic approach for those patients with positive samples. And last but not least, we'll talk about neurologic syndromes due to herpes 1 and 2 and varicella zoster. It's well known that these viruses are neurotropic viruses with different molecular structure and different patterns of neurological diseases, but with similar features in neurologic disease. Herpes 1 is well known that is the main cause of encephalitis worldwide, and has also been associated with other neurological peripheral diseases, mainly to Bell's palsy. Herpes 2 can produce encephalitis mainly in immunocompromised hosts and in neonates, and has also been associated with recurrent meningitis. And we all know that encephalitis, if not diagnosed, can produce a very high mortality that is above 70%. This slide, this table, summarizes neurological complications that have been associated with varicella zoster or herpes zoster, and are both related with neurological damage and, as we said before, to vascular damage that can be produced in central nervous system. As we said before, since the main cause of encephalitis all over the world is herpes 1 and 2 and varicella zoster virus, I report this interesting study that has been performed in Barcelona, including adult patients with encephalitis. They almost found the etiological diagnosis in around 80% of the patients. As we can observe, most of the patients were herpes 1 and 2 and varicella zoster virus encephalitis, followed by listeria and tuberculosis. But one of the most interesting data they report in this study is a different approach for the mainly management of these patients to avoid unnecessary exams for the approach of encephalitis. They tried to perform a stepwise algorithm for etiological diagnosis. They first detect encephalitis, and they performed only varicella zoster virus, herpes 1 and 2, and herpes 2 PCR associated with Listeria PCR and blood cultures. And with only this panel of exams, they could detect about 54% of the causes of encephalitis, avoiding unnecessary costs and avoiding unnecessary treatment. They performed thereafter a second step, mainly for immunocompromised patients, that allowed to detect 12% of other causes of encephalitis. But I think that is a very interesting study because it allows a new, different approach for the daily practice nowadays. So in conclusion, I think that the development of PCR analysis has made diagnosis of asymptomatic viral shedding possible in many specimens, mainly for the central nervous system and ocular specimens. That although genital herpes has always been related to herpes 2, herpes 1 is responsible for an increasing proportion of genital infections with different clinical pattern, including in neonatal infections. That there is an emerging role of herpes infection in IBD disease that we have to know also because these patients are always at risk nowadays with the new biologic treatments. There is no clear role of herpes 1 and 2 as a pathogen in respiratory secretion. We don't know at the moment if there is an innocent bystander or a real pathogen, and we need to do more research to take care about the intensive care patients. There are very interesting data with the use of varicella PCR for the role in vasculopathy and the risk of cardiac and stroke events, and also with autoimmune aortitis and vasculitis. And PCR against herpes 1 and 2 and varicella zoster virus can also allow a new, different, interesting approach in the daily practice for encephalitis. Thank you.
Thank you, Professor Baldanti. Good afternoon, everybody. I'm going to present you our experience with the DiaSorin Simplexa solution for the diagnosis of meningoencephalitis in our laboratory. So as you all know, meningitis and encephalitis are syndromes that refer to the inflammation of the central nervous system, either meningitis or encephalitis, and maybe meningoencephalitis, of course. There are numerous etiologies, but one of the first ones are represented by the infectious pathogens, and especially viruses, but also bacteria, fungi, and parasites. But there are also non-infectious causes, autoimmune diseases, cancers, or some drugs. And we have to keep in mind that there remains some, maybe half of the encephalitis remain with unknown etiologies. So according to many studies performed in Europe and United States, viral meningitis are due to, first of all, enteroviruses, but also varicella zoster virus and Herpes Simplex virus 2. And viral encephalitis, the first one, as it has been previously said, is Herpes Simplex virus 1, and then varicella zoster virus. Regarding the clinical presentation, the symptoms are not pathogen-specific, and this clinical presentation may be from the self-limited and benign disease to a life-threatening disease and even the death. The prognosis and the outcome of meningitis and encephalitis vary greatly between patients, and they depend primarily on the time of initiation of the therapy, which is based on the identification of the underlying cause of inflammation. So an etiologic diagnosis is crucial in order to establish the appropriate control measures and an early specific therapy, and even to avoid unnecessary use of antibiotics in case of viral infection. These syndromes remain uncommon diseases in developed countries. Here we have the incidence of meningitis and encephalitis, but they remain associated to a substantial morbidity, mortality, and costs. And here are presented two studies performed in the United States regarding the burden of meningitis and encephalitis. And as you can see, regarding the mortality rate, it ranges from 0.4 to 11.4% for meningitis, and the cost of estimated cost of 1.2 billion for meningitis, and for encephalitis, a mortality rate of 5.8 to 17.1%, and the cost of almost $2 billion. So now regarding the etiologies of the infectious meningitis and encephalitis, here is a prospective study which was recently performed in Denmark concerning 562 cases of infectious meningitis and encephalitis among adult patients. And as you can see, and as it has been previously said, the two main responsible agents for encephalitis were HSV1 and VZV, and regarding viral meningitis, the first ones were VZV, and then enterovirus and Herpes Simplex type 2. But of course, you have to keep in mind that arboviruses may be responsible for these syndromes, especially for patients who travel, as presented this morning by Professor Anna Papa. So this is the results of a French prospective study more than 10 years ago, concerning 253 immunocompetent individuals. And once again, you can see that the etiologic agent of the encephalitis, the first one was HSV, and especially HSV1, and then the second VZV. And then regarding the bacteria, Mycobacterium tuberculosis and Listeria were just after. But you have to see that in this study, almost half of the encephalitis remained without any etiology. So according to these results, some French guidelines were proposed at the end of last year for the management of the infectious encephalitis in adults. So within the first 2 days of hospitalization, an initial anti-infective treatment has to be proposed to the patients, consisting of acyclovir to treat possible HSV or VZV infection, and amoxicillin for the Listeria. And of course, during these 2 days, the microbiological diagnosis has to be performed, and especially HSV, VZV, enterovirus PCR on the CSF, but also the ground strain and culture on the CSF, and the blood culture. And then, according to the results, if HSV PCR is positive, of course, acyclovir treatment is maintained, and the antibiotics are discontinued or stopped. If the VZV PCR is positive in the CSF, acyclovir is maintained at a higher dose than HSV, and antibiotics are stopped. If the enterovirus PCR is positive, all treatment can be stopped. If, of course, there is a positive culture for bacteria, antivirals are stopped, and the antibiotic treatment is adapted to the strain of bacteria that is detected. And if all results are negative, according to the context, the acyclovir may be continued until HSV and VZV diagnosis reevaluation within the 4 days after the onset of neurological signs. So according to these different studies, and according to the French guidelines, it seems to be quite, let's say, logical or reasonable to have a multi-step strategy for the diagnosis of viral meningoencephalitis, especially according to the type of patients. If it's an immunocompetent patient, immunocompetent individual who did not travel or who does not live in a region where there may be some arboviruses, the viruses you have to test in the first line are HSV1, HSV2, VZV, and enterovirus. And those viruses cover the great majority of the cases of viral acute meningitis or encephalitis. Of course, if the patient is immunocompromised, then in addition to those 4 viruses, you have to test opportunistic viruses such as cytomegalovirus, EBV, HSV6, GC virus, and even HIV in HIV-infected patients, of course. And for travelers, once again, in addition to the 4 first viruses, you have to test arboviruses, which are different according to, of course, the country or the region where the patient traveled. So now moving to, let's say, our experience in our laboratory. So the Virology laboratory is settled in the Pitié-Salpêtrière Charles Foix University Hospital in Paris, which has 2,030 and 300 beds, covering medicine, surgery, emergency, and ICU. It's an adult hospital. There is no pediatric department. And you can see there are many specialties, and especially infectious and immunological disease and HIV infection, of course. A great department of transplantation, solid organs, but also hematopoietic stem cells, and also cancer. Regarding the activity of the laboratory, well, it's a quite classical activity with, of course, a lot of molecular tests by real-time PCR, but also serology. And a big place is reserved to the sequencing, and especially for the genotyping resistant testing for HIV, HBV, HCV, but also herpes viruses. And we also have the viral isolation cell culture, especially for the National Reference Center. Because in fact, our laboratory is part of the National Reference Center for herpes viruses, that I'm in charge of it with Dr. Sonia Burel, who is here in the room. And in the case of the National Reference Center, we receive a lot of samples from France, all of France, for the genotypic resistant testing for HSV1, HSV2, VZV, and CMV. And in this work, we can identify, and sometimes we have to characterize some new mutations that are maybe implicated in the resistance of antivirals, because the knowledge is not so high than for HIV or hepatitis C or B. We also perform the viral isolation in cell culture to get a big collection of HSV and VZV clinical isolates to perform research. And we may help some colleagues in other laboratory for diagnosis difficulties, either in molecular or in serological techniques. And as a national reference center, we also organize national quality controls every year. We try every year for the molecular diagnosis of herpes virus infection and for resistance testing. So now focusing on HSV and VZV molecular diagnosis. So this is our activity of HSV and VZV PCR last year. So you can see we tested, well, we performed more than 6,000 HSV PCR and almost 3,000 PCR for VZV, especially on CSF, here in blue, about 1,200. But also, as you can see, we are able to test swabs, blood, bronchoalveolar fluids, other biological fluids, biopsies, maybe some ocular aqueous humor, the ocular samples, and of course, external quality controls, which is a big part of the activity. So about 3 years ago, we implemented the Liaison MDX in the lab. So at that time, it was the 3M integrated cycler, and we implemented this rapid technique for the diagnosis of HSV 1 and 2 infections, especially for herpetic meningoencephalitis, or let's say suspicion of herpetic meningoencephalitis, but also the genital herpes in pregnant women at the time of delivery, and for the suspicion of neonatal herpes. So just to give you an overview of our molecular biology workflow in the lab, so don't be afraid, it's a little bit complicated, but maybe just like all in the laboratory. So we perform the LISA MDX for HSV 1 and 2 detection in genital swabs from pregnant women, swabs from newborn, and CSF. And then CSF and other samples are extracted on the EMAG. Whole blood are extracted on the QIAsymphony, and we also have another extraction for the aqueous humor. So you can see we have many manufacturers in the lab. HSV 1 and 2 PCR is performed with the Arthur's kit on the Rotogene, and VisitV PCR we still have a homemade PCR, and also for the HSV in the bronchoalveolar fluids, because we perform in parallel HSV PCR and a cellular gene PCR, because we quantify the virus according to the cells, just to have a cutoff of HSV pneumonia. So now moving to the Simplexa test. So we use the Simplexa HSV 1 and 2 direct kit, but we have a laboratory adapted protocol using a low volume of clinical samples. As it has been previously said by Michel, sample volume recommended by the manufacturer is 50 microliters. It's low, yes, but it may be maybe sometimes high regarding CSF. So in 2015, there was an evaluation in the Mayo Clinic by testing 50 HSV positive CSF in parallel with different volumes, as you can see here, and they could demonstrate that all samples were detected down to a volume of 25 microliters. So last year, we decided to perform a little bit the same evaluation. So we tested in parallel 21 HSV positive samples with 50 microliters or 25 microliters. So as you can see here, we tested the QCMD samples, CSF, swabs, blood, bronchoalveolar fluids, of course the HSV Simplexa positive control, and we could validate the use of 25 microliters of samples in our lab. Of course, it's an off-label use. The agreement between 50 microliters and 25 microliters was 100%. All samples were positive with both volume. And regarding the difference of CT value, because in the Mayo Clinic article there was no idea of the CTs, you can see that in fact it can be with 25 microliters either higher or lower. It depends, and sometimes there is no difference between the two volumes. In fact, in the MDX, only 10 microliters are required to perform the test. So even if you put only 25 microliters, the 10 required microliters are here to perform the test. And you can see here the median difference of CT values was about 0.23, which is quite good. So we implemented the technique with the 25 microliters. Of course, we have a quality control policy in the lab, so we use a positive control once a week on both instruments because we have two MDX, and we record the results in the specific software. So you can see here the Levy-Jennings graphs and the evolution of the mean of HSV1 in CT and the CT of HSV2, and with quite low standard deviation. We also use an internal quality control, which is the Acrometrics, the HSV1 and HSV2 low-level controls, once a week on both instruments, and once again we have quite stable values for HSV1 and HSV2 with quite low standard deviation. And last but not least, of course, we use the external quality assessment program. We participate to the QCMD program, and for this virus, of course, the HSV DNA UK program with 2 challenges per year. And here are the results. Maybe you cannot read, but the results of the challenge of the beginning of the year. And what we have to see is that all is green, so all is okay. So now, as Michel said, there is the VisitV direct kit. So we have the great opportunity to evaluate this kit, and the thing I wanted to do is to test 50 microliters, 25 microliters. So this is what we performed this this summer with 23 positive samples, 2 CD samples, CSF, some swabs, and the Herpes Simplexa positive controls. And once again, we could validate the use of the 25 microliters. Here are the results. So all the samples were positive, both with using 50 and 25 microliters. I have to say that one QCMD sample, which was an educational one, was only positive once out of three tests. But for the other samples, you can see here, once again, a variation in one higher or lower for the CT value, but the mean of different CT is about 0.18, which is really, really very low. So we could validate, once again, it's an off-label use. So now in the lab, we are going to implement very soon the VisitV kit. So as a first-line diagnostic test for all viral meningitis and encephalitis, we can perform as a first-line test HSV 1 and 2 PCR and the VisitV PCR on the CSF on the liaison MDX. And then, if negative or according to the context, especially if the patient is immunocompromised, then we can perform, let's say, a real extraction and look for the opportunistic infection by CMV, EBV, or HHV6. At the time, since we are a hospital with adult and no pediatric department, we do not perform the enterovirus and even paracovirus PCR, so the samples are sent to another lab near the lab where we work. And of course, we do not perform arboviruses. We send them to another lab or even a reference center in France. But what we would like, what we expect, is to get an enterovirus and paracovirus kit on this machine so that we could perform as a first-line test HSV 1 and 2 and VisitV PCR, and maybe in the same well, multiplex PCR, and then another one for enterovirus and paracovirus test. So that as a first-line test, we could test the 4 viruses that are responsible for meningitis or encephalitis in adults according to the different studies. And then, if the results are negative, according to the context, we can perform the other opportunistic viruses, and of course, we will send arbovirus test in another laboratory. So in conclusion, meningitis and encephalitis are uncommon diseases, but associated with substantial morbidity, mortality, and cost. According to the different European studies, but also studies performed in the United States, HSV and VisitV are the leading causative agents. The laboratory diagnosis of HSV and VisitV CNS infections is critical for the therapeutic management of the patient. And the DiaSorin HSV and VisitV Simplexa direct kits constitute a reliable solution to our eyes and to our opinion, with a short delay to obtain a PCR result within 1 hour, and the possibility to test low volume of CSF. Once again, it's an off-label use. So, σας ευχαριστώ για την προσοχή σας. Thank you for your attention.
So good afternoon, everyone, and thank you for attending the symposium today. So I'm all the way from just south of Los Angeles in a town called Cypress, near Disneyland, just to orient you all. So today it's my pleasure to talk about DiaSorin molecular solution for fast and sensitive testing for herpes simplex virus 1 and 2, as well as for varicella zoster virus. But also just to talk about the comprehensive solutions that we now have available due to the increase in the sample types that we have studied and have claimed for the test. Okay. So just to start with, we have a long history of experience for molecular testing of herpes simplex virus at the company. So prior to becoming DiaSorin Molecular, we were Focus Diagnostics, and at the time we started developing primer pairs for very sensitive detection of herpes simplex 1 and 2. So this goes back to 2009 timeframe with the offering of some primer pairs. And then we did the studies to CE mark and then FDA clear the very first test for detection of herpes simplex virus from cerebral spinal fluid. And so that was in the 2014 timeframe. We went on after that to achieve clearance for genital swabs, both for CE marking and then also for FDA. And then most recently, we've expanded our sample type claims by doing the studies to cover all of the common swab types, cutaneous and mucocutaneous, in a variety of transport media, to now have both CE mark and FDA cleared versions of the HSV 1 and 2 for both cutaneous, mucocutaneous swabs as well as CSF. So this really offers a great flexibility, and we're the first test on the market to offer this flexibility with one test that can cover all of these different varieties of sample types. Wrong way. So as you already heard from the first speaker, herpes simplex virus infections can present a broad challenge because of the variety of different specimen types that this virus can present in, wide spectrum of presentations and diseases, and a good test can help guide management and the appropriate therapy. So as you already heard, the mortality of HSV-1, for example, if left untreated, is greater than 70%. Neonatal infection by HSV-2 is devastating. Disseminated disease could occur up to 25% of patients. And so having a test for CSF or even for swabs in that case is important. Over in the green on the right-hand side, recognition of genital herpes is also important, both for counseling and to prevent the spread. And then, of course, for mucocutaneous sample types such as ocular swabs, of course, diagnosis of an eye infection by HSV is very important and critical to protect vision. I'm going to get this right. Okay, so in terms of testing and diagnostic techniques, clinical sensitivity and specificity is highly important, but so is a fast diagnosis. And as you already have heard, PCR is 1.5 to 4 times more sensitive than some of the traditional methods. And just to get a snapshot of this, I show here, the typical sensitivities and that are presented here for viral culture or microtiter plate, shell viral culture, or Elvis, at least for lesion swabs for both initial and recurrent infections. So really quite poor results, quite poor sensitivity in comparison to PCR techniques. And of course, not just for cutaneous and cutaneous swabs, but also definitely the gold standard for detection of this virus for aseptic meningitis is the testing by PCR. So that brings me to a paper that was recently published, which really speaks to a fast and accurate diagnosis of herpes simplex 1 or 2 in cerebral spinal fluid specimens linked to clinical outcomes. This paper was published in JClin Micro last year by Jennifer Dean Bard's lab from Children's Healthcare of Los Angeles. And they are using our Simplexa HSV 1 and 2 test for cerebral spinal fluid. And the outcome studies actually showed that they were able to reduce the turnaround time and result for diagnosis by 14.5 hours. So when you're talking about a baby and you need to make this diagnosis very quickly, these are critical hours and a lot of time saving, a lot of impact to the patient. The mean time from specimen collection to acyclovir discontinuation, another important feature. You want to make the right treatment for the patient and get the baby off of an antiviral if it's not needed, 17.1 hours shorter. And the mean duration of acyclovir therapy was also significantly reduced. So that implementation of rapid PCR can decrease the turnaround time and also the unnecessary use of acyclovir. So now let me tell you about the Simplexa HSV 1 and 2 direct kit. So as I already mentioned, it's currently the only CE marked test on the market and also FDA cleared that in one kit, using the same run and the same parameters, can detect HSV 1 and 2 for both the CSF specimens as well as the broad spectrum of cutaneous and mucocutaneous swabs. We use our instrument. The DiaSorin booth is down that way if you want to see it. It's quite a small instrument, and we use the direct amplification disc for this testing. Also important and critical, especially in the case of CSF from babies, a very, very small amount of cerebral spinal fluid is required for this test, and it still gives that great sensitivity and the speed of results. Only 50 microliters of precious CSF is required. And as I mentioned, we have both cutaneous and mucocutaneous swabs, but those can present in a variety of the different common transport media types that may show up in your laboratory. Everything from BD, UVT, through the REML media types and CoPen UTM. Our direct amplification disc allows testing of 1 sample up to 8 samples, and the disc is reusable, and the time to result is about an hour. It's moderate complexity in terms of the US rating scale, but what that means is it's extremely easy to use, and minimally trained users can be trained to use this very simply. So the workflow here is sample to answer, ready to use reagents that require no extra mixing or anything like that. Come prepared in a box, you thaw it out, and it's ready to squirt into the disc. No mixing or pouring or rehydrating. There's no extraction needed, which is a hallmark of our direct chemistry, both for this test and also for the other tests we offer in this direct amplification format. And the hands-on time is less than 1 minute per sample. We also have liquid sensing to ensure that the user has in fact added specimens. Not every IVD system on the market actually does this kind of a check, but in our case we have a safety check to make sure that specimen has been added and no precise pipetting is required. The bottom of the slide shows our very simple workflow, which is driven by barcode scanning, and we like to call it the 7 S's. So in about less than 1 minute, scan, 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 squirt, squirt, seal, and start. And it's as easy as that. So the customer adds 50 microliters of unprocessed, unextracted patient specimen and 50 microliters of the reaction mix, and then loads the disc, puts it onto our system, and starts the run. Once the run has started, the disc is able to meter the correct amounts of patient sample and reaction mix. There are metering cups present inside of the disc that measure 10 microliters of sample and 40 microliters of reaction mix, and the material is held there. Inside the instrument, a gantry comes out over the disc. This gantry has both optics on it as well as a laser. The laser is able to direct its heat energy onto the disc, and shown here is a laser valve. So the laser blows that valve open, and then after that goes back inside the instrument, and the disc spins again. What has happened by that laser valve actuation is that a channel has been opened, so that now when we spin the disc again, the sample is able to travel from that 10 microliter metering cup down into the reaction chamber down in this rectangular box at the periphery of the disc, where we perform a fluid check to make sure that the sample has been added by the user. Then when we're ready, the gantry comes back out over the disc, opens the other laser valve on the right-hand side, then spins again, and the 40 microliters of metered reaction mix then is able to enter this rectangular chamber where we have a 50 microliter PCR reaction. Now let's look at some performance data for our kit. So this data shows our most recent clinical study that was conducted for the addition of cutaneous and mucocutaneous swabs. And so we were comparing the Simplexa HSV 1 and 2 direct result to a composite reference method, which included culture, bidirectional sequencing, and an FDA-cleared nucleic acid test. And a 2 out of 3 rule was applied. In other words, if 2 of those are positive, then that result stands as positive up against the Simplexa result. And you can see for all 4 of the sample types here, HSV 1 and 2, for both cutaneous and mucocutaneous, we see very, very high positive predictive agreement and very, very high negative predictive agreement. So we have very nice performance from this test. Going a bit further, we've studied this test performance against another CE-marked and FDA-cleared nucleic acid test for HSV, including cutaneous and mucocutaneous swabs that's available on the market. This is the Quidel test. And you can see the results for Simplexa on the left, and on the right, or up on the top, the Solana results for HSV 1 on the left and HSV 2. This slide's focusing on the cutaneous samples. And I want to draw your attention to the blue boxes. So in each case, there were 7 or 11 samples that were detected by Simplexa that were missed by the competitor NAT. And when we did further analysis by bidirectional sequencing, we confirmed that each of those was positive. So Simplexa delivered the correct results. And actually, in some of these cases, samples that were missed by Quidel were actually known contrived positive specimens. Going further to the mucocutaneous story, it's very similar. There were no discordance for the HSV 1 results, but HSV 2, we actually saw 22 samples that were detected by Simplexa that were missed by Quidel, and all of them confirmed by bidirectional sequencing. 2 of them were native samples, 20 of them were known contrived positives. So once again, the Simplexa result is giving a nice sensitive result compared to Quidel. Before I talk about the cerebral spinal fluid results, I just wanted to hit on one other important point, which is the diverse age groups that were covered in our clinical studies, both for the cutaneous and mucocutaneous swab study, as well as the cerebral spinal fluid study. So on the left, you can see our swab samples with age stratification, and on the right is our CSF study from back in 2014. I think if you look at the package inserts or information available about a lot of tests on the market, they probably do not have such nice age stratification, particularly including the neonate and infant populations, which are shown here. So we do have samples that are covered. We don't have enough for a pediatric claim per se, but certainly these samples have been tested within our test. So from neonate all the way to older adults, We have had those samples in our studies, including in our CSF study, I believe we had a 90-year-old patient that was positive in our test. Now switching over from swab performance to the cerebral spinal fluid performance. And so this chart shows the results for our direct test for HSV1 and 2 with two categories of samples. The first being prospective encephalitis patients, and the second being HSV molecular positive patients. So as I mentioned, the encephalitis patients were the prospectively collected during the time of the clinical study in the US back in about 2013. And HSV molecular positive patients were pre-selected samples that were positive by a molecular herpes virus test, lab developed and validated test at the time. So you can see we have nice high positive agreement for HSV1 and high agreement, at least in agreement with the LDTs that were PCRs for HSV2 as well, and very high negative predictive agreement. One more study I wanted to mention regarding HSV and CSF was published by Matt Vinegar from Mayo Clinic and Journal of Clinical Virology back in 2014. And this was at the time that Mayo Clinic actually adopted our Simplexa HSV1 and 2 test for CSF. At the time, they compared our test to their routine method running at Mayo Clinic, and that routine method included extraction and concentration of a sample for CSF prior to running with the Roche ASR reagents, which gave a melt curve analyses. What you can see on the chart on the left actually shows the agreement, including some indeterminates that were delivered by their routine methodology. Interesting in the commentary and the conclusions is that Simplexa called those negative initially, while their routine tests were indeterminate, and so it had to be repeated. And then those tests were also confirmed by Altona. So Simplexa delivered the right result, the negative result, the first time. And then also at the bottom of the slide includes an additional conclusion made by Dr. Vinegar about the reduction in overall turnaround time for that result from CSF, reducing the turnaround time by 4-fold, having a significant impact on the management of patients being evaluated for CNS disease. So a very sensitive and very fast result from this HSV test. And now turning to a brand new offering, I'm happy to say that as of about 2 weeks ago, our VZV direct test, which is in the same format as our HSV test, is now CE marked. So this is also for use on the Liaison MDX instrument. It's for testing CSF for patients with signs and symptoms of VZV infection of the CNS. Once again, we still use that very precious and small amount of 50 microliters of CSF. You can run from 1 to 8 samples at a time. And the beauty of this test is it's been designed to run at the same time on the same disk run as the Simplexa HSV1 and 2 test. So depending upon your lab and how you foresee testing, whether that's to test HSV1 and 2 and VZV at the same time, or to test first for HSV1 and 2, and then if the sample's negative to reflex to VZV, we have a flexible solution that we can offer you. We have the same quick time to result in 60 minutes, and once again, it's easy to use, moderate complexity. This is the same exact workflow. This is the same slide that I showed for Simplexa HSV1 and 2. So if you're familiar with that workflow, it's identical for the VZV test. And here I'll show you the clinical agreement that was used for the CE marking study. The US clinical study is currently ongoing. But in this study, we had 180 samples that were from leftover pooled CSF specimens that we spiked with virus. And you can see we have agreement, 100% positive agreement, 98.4% negative agreement versus a sequencing assay. The 2 specimens that were in disagreement were actually, once again, known contrived positives. So I think this really shows you the theme. We have a very sensitive test. One of the reasons for that, we suspect, is because we do not extract. And this is so that we do not lose anything to extraction efficiency. The entire amount of virus is there in the specimen. Once the virus is cracked open, the nucleic acid is there for our reagents to query. And so we have very high sensitivity as a result. One other thing we took a look at with this VZV test was the limit of detection. In the US for FDA, we always have to report things in plaque-forming units or TCID50s. But I think it's important to look at the actual copies of detection per reaction. And so we've done this for VZV, and the study currently is ongoing for HSV. We used a droplet digital quantified stock from Exact Diagnostics and 2 different VZV strains there, Ellen and 9929. We used 2 different methodologies for limit of detection, one called traditional, which basically means we do 32 replicates, 31 out of 32 or 32 out of 32, we get 95% detection, anything less is your cutoff. But Probit is a little bit different. We run additional replicates right around the suspect LOD, and we typically get a linear regression which points to a slightly lower copies per reaction. So we like people to make their own conclusions about which kind of data analysis they prefer. But the long story short is that our sensitivity for VZV detection seems to be in the low double-digit amounts of copies of this virus per reaction. We suspect we have about the same detection for our HSV test, and as I said, those studies are ongoing. So in summary, we have the Simplexa HSV 1 and 2 test, which is able to provide a fast and sensitive diagnostic answer for both CSF and now for that broad variety of mucocutaneous and cutaneous swab types. VZV Direct for CSF is also now available and can be run simultaneously with the Simplexa HSV 1 and 2. Importantly, both tests require only that small amount of cerebral spinal fluid, 50 microliters, and generate results in about an hour. And as some of the data has shown from the studies that have been done with our tests, that fast turnaround time and the rule-in, rule-out ability of this with HSV and VZV as the cause of meningitis or encephalitis could really help steer antiviral management and patient management as a result. And with that, I'm happy to take any questions. Thank you.